To double click on the four horsemen just a little bit, you mentioned what those four are, but do you also want to talk a little bit about for each of them what we know in terms of prevention, right? So if medicine 3.0 prevention is really important, how do you think about our knowledge of those diseases as it relates to someone who is trying to live as long as possible?
Sure. So we'll take them from the top. So the atherosclerotic diseases, along with the fourth horseman, which is the metabolic diseases, are probably the two that we have the most insight into as far as what are the pathophysiologic drivers. And therefore, we either theoretically or in some cases practically also have, I think, the best insight into how to prevent them. So ASCVD is a disease that has both a genetic component and an environmental component, but it really doesn't have much of a component of luck as far as we can tell. So, stochastic processes involving mutations doesn't seem to play a role, right? There's just pure causality from the standpoint of environmental triggers and from genetic inheritance. So both of those factors play through three pathways, all of which are important. So first is a lipoprotein pathway, second is an endothelial pathway, and third is an inflammatory pathway. But I realize as I'm saying that, it doesn't make a lot of sense. So I'm going to try to step back and put this into English. The three things that have to happen for atherosclerotic disease are as follows. The first is a molecule called a lipoprotein, which carries cholesterol through the body, and specifically a lipoprotein that has an ApoB protein on it, because there are lipoproteins that don't have ApoBs on them, and we don't have to worry about those. But the lipoproteins that have ApoBs on them can enter the artery wall when the endothelium is intact, but they do so more prevalently and more easily when the endothelium is damaged. The endothelium is simply the lining of cells on the innermost membrane, closest to the artery or outermost from the standpoint of the artery wall, the one that is most in contact with the circulation. If those ApoB-wrapped lipoproteins get trapped inside the endothelial layer, a chemical process known as oxidation takes place, and that leads to inflammation. What that means is the body thinks something is wrong and I need to fight it. Just as when you get an infection, a healthy immune system detects the inflammation caused by the microbial agent and it sends the troops there to get rid of it. But in this case, the insult does not come from an infection, it comes from the oxidation of the cholesterol contained within the ApoB particle as it sits in the endothelium. And that process initiates a devastating cascade of events that ultimately can create so much damage in the wall of the artery that it can lead to a rupture of the plaque, which is the repairing process. The rupture of that plaque acutely leads to blood loss and ultimately oxygen loss to the muscles of the heart beyond the point of that blockage. That process is known as a heart attack, and about 50% of the time, it is fatal the first time a person has one. So if you want to think about preventing cardiovascular disease, ischemic cardiovascular disease, you have to have an insight into all of those things. You have to be thinking about, how do I have fewer ApoB particles? Because the more of those particles you have, the more of them that are going to enter the endothelial space. The data on this is as unambiguous as any data are in medicine, from clinical trials, epidemiologic trials, and Mendelian randomization. In other words, you have the only three layers of evidence you can ever look to: experimental data, MR, and clinical epi, and they all say the same thing. There is a log linear reduction in ASCVD as ApoB goes down. The second thing you have to do is you have to protect your endothelium. So anything that aggravates and weakens and makes the endothelium more vulnerable to penetration by ApoB is problematic. And the most common factors that we think are doing that are smoking, blood pressure, and very likely the metabolic conditions that cluster with insulin resistance, hyperinsulinemia, and type 2 diabetes. So some combination of elevated glucose, elevated insulin, and other metabolic byproducts such as homocysteine, uric acid, all of these things serve to weaken the endothelium along with elevated blood pressure and smoking, and that creates a greater susceptibility. Again, it's not surprising that all of those things pose about an equal risk to cardiovascular disease, as does the presence of elevated ApoB. And then the third piece of the puzzle, and the one for which we really don't do much directly in the way of treatment, is the higher the inflammation, the more likely the higher this is going to be. And the reason this is probably lesser of the three is, with very rare exceptions, is it a direct therapeutic tool? In other words, we clearly therapeutically address the first two, right? We therapeutically lower ApoB, we manage blood pressure, we tell people to not smoke, which of course is a therapy. We, use exercise and nutrition to manage metabolic health and even pharmacology. But directly from a pharmacologic standpoint, we don't really manage inflammation. We can. There are a couple of agents that are used, somewhat not impressively, and maybe somewhat on the margins impressively. But most of the evidence around reducing inflammation probably comes from doing things much more broadly around nutrition, sleep, and exercise that we've talked about elsewhere. So in a nutshell, that's really what it comes down to. And it's for that reason that I'm often making a very bold statement, which is, even though cardiovascular disease is the leading cause of death in men, in women, in the United States, but also in the world, it doesn't need to be. It really, really doesn't need to be. And it is a very bizarre tragedy that, 19 million people a year still die from cardiovascular disease, given how much we know about what causes it and how many tools we have to prevent it.
So that's the first, you kind of mentioned the first, second horseman there. How do you think about prevention for the others, which is neurodegenerative diseases and cancers?
Yeah, so let's take them in order. So cancer would be the next most deadly of the horsemen. And here is one where a lot of what I said with respect to heart disease is actually quite different. In heart disease, we really have a pretty clear sense of what the genetics look like. So there are a handful of genetic things like familial hypercholesterolemia, which is a very, very heterogeneous condition that raises apolipoprotein B, LP little a, which we'll save for another time. We've got lots of content on that. But when it comes to cancer, we know that, boy, there are some really clear and obvious genetic drivers of cancer. Like, there are a handful of genes, some that many people have heard of, such as BRCA1 or BRCA2, which are heavily associated with breast cancer, or Lynch syndrome, which would be heavily associated with colon cancer and other types of cancer. But for the most part, when we say that cancer runs in a person's family, we still aren't really even able to identify the genes through which this is transmitted. It appears to be very polygenic. Furthermore, while we know of at least two significant environmental triggers for cancer, smoking and obesity, and I'll say more about obesity in a second, we actually have very little to say about many other triggers. Despite what people would have you believe, we have very little insight about, if at all, foods, specific foods at isocaloric amounts. So we can talk about an abundance of food because that factors into the obesity trigger. But if we're talking about a bunch of people eating an isocaloric, energy balanced diet, again, despite all of the propaganda around this, oh, red meat this or soy that or whatever, there's actually just the scantest of evidence to suggest that any of these are promoting cancer in the slightest way. So when you take all of this together, what you realize is that, okay, smoking is clearly driving cancer. Obesity is clearly driving cancer. Not all cancers, but many cancers. About 2/3 of cancers have a very strong tie to obesity. I think if you look under the hood of that, you'll realize it's probably not the excess fat per se or the adiposity that's driving cancer, and rather it's the growth factors that are doing it. So obesity comes with more inflammation, comes with more growth factors such as insulin and IGF, and it seems more likely that those are the things that are actually leading the increase in cancer. But that leaves a bit of a vacancy in terms of what else explains it. And this is where, a scientist like Bert Vogelstein and others would suggest that, look, there's actually just a component of really bad luck here. There are mutations that occur. Every cancer begins with a mutation, and most of those are somatic mutations. That means that most of those are mutations that occur in cells that were developed normally, right? So these are your germ line, the cells you inherited. These were normal cells, but then mutations were acquired. And mutations fall into one of two categories. These are either mutations that are tumor promoting, so oncogenic mutations, or they are mutations of tumor suppression. So we have genes that are set out to suppress cancer. And if you get a mutation in one of those, the body loses the ability to suppress cancer. And then we get mutations in genes that turn cancer on. And again, a number of these are inherited, but many of them, most of them are acquired. And the what is vexing us still. And again, I think the best working hypothesis is that bad luck plays a lot of role in that. Now, it would be a topic for an entirely different podcast to look at other things that may be triggering those mutations. Again, in some cases, we know that viruses play a role in those mutations. But what I'm really talking about is, where do the majority of these come from? And anyway, that's an area of huge interest. The other problem with cancer that also is not afforded to cardiovascular disease is the treatment options are fewer. Or I shouldn't say are fewer, I would say are less effective. So a person today who has advanced cardiovascular disease has a much better prognosis than a person today who has very advanced cancer. A person today with stage 4, i.e. metastatic, endothelial tumors, so that means a solid organ tumor like breast, lung, pancreas, prostate, colon, one of the sort of quote unquote bread and butter tumors. A person today who has one of those cancers that has spread from its original site to a distant site, that's metastatic or stage 4 cancer, that person has about the same 10-year survival as a person did with that tumor 50 years ago. They have a much longer median survival. They will live longer. They might live for 5 years instead of 1 year, and that's nothing to sneeze at. But they're not cured at any higher a rate. And obviously that's a discouraging statistic. So that's, as we think about cancer, we obviously think the first and most important thing is to do everything you can to avoid getting it. But as I alluded to, that playbook is not as thick as the don't get heart disease playbook. And that leads to a very controversial thing that I talk about, which is the importance of early and aggressive screening. And again, we don't have to go into that now. We've already devoted tons of content to the arguments for and against that approach, but hopefully this explains why that is still a position I hold.
And so, looking at the last of the horsemen, neurodegenerative disease, such as Alzheimer's, something we get asked a lot. how does that look in terms of what you kind of discussed on cancer, cardiovascular disease, as it relates to prevention?
Well, I would say it's a little bit in the middle. In other words, I think we actually have a slightly better sense of some of the causes, not in all cases, but certainly with Alzheimer's disease, we're getting a much better sense of which people are susceptible, what genes play a role from a genetic susceptibility standpoint. And genes do play a pretty big role there. And we also understand the other factors. And part of the reason for this, Nick, is there's a very simple but surprisingly accurate adage, which states, what's good for the heart is good for the brain. And study after study after study have demonstrated the following. Every intervention that we take to lower the risk of atherosclerotic cardiovascular disease also reduces the risk of dementia. And that means Alzheimer's disease, vascular dementia, which are the two main ones, but also other forms of dementia. So that means having better metabolic health, having lower ApoB, having lower blood pressure, not smoking. Those things dramatically reduce your risk of cardiovascular disease, and they dramatically reduce your risk of Alzheimer's disease. Now, an area where dementia has an even bigger positive impact in intervention than cardiovascular disease is with that of exercise. So it's no surprise that exercise improves a person's odds of not getting and or surviving cardiovascular disease, cancer, dementia. But I would say that the evidence for the benefits of exercise are both greater in magnitude and greater in confidence when it comes to the prevention of neurodegenerative disease. So, it's interesting because I do think that many people fear dementia more than any other condition. And there are very obvious reasons why that would be the case. And it might be that in our practice, we're a bit more optimistic than most based on just the nature of what we do and the types of people that are in our practice, meaning people who really study prevention and really look at kind of these early signs of dementia and look at how specific interventions can make a difference. But unfortunately, the flip side of that is that of all the chronic diseases, the dementing and neurodegenerative diseases are the ones for which we have at this time virtually no viable therapeutic options. So the real name of the game with neurodegenerative diseases, but specifically the dementing diseases, and the only other one I'll really mention here briefly is Parkinson's disease, because it's the most prevalent movement disorder, is that avoiding them is the first, second, and third priority on a list of 3 priorities. Once we get into treatment land, at least at this point in time, it's not very promising. So these are both diseases where having as high a reserve as you can make a big difference. So the higher your cognitive reserve and the higher your movement reserve, the more resilient you are to the effects of these conditions. I think I should just state at the conclusion here that we shouldn't ignore the fourth horseman, which is, of course, the spectrum of metabolic diseases. As I said kind of at the outset, I think along with cardiovascular disease, we really have a pretty clear sense mechanistically of what's driving this. This appears to be primarily a consequence of overnutrition. So energy imbalance is really the driving factor of insulin resistance, and insulin resistance is really the driving factor of the downstream effects that ultimately lead to everything from fatty liver disease, type 2 diabetes. And again, these diseases in their own right are quite harmful and devastating. But their real danger of them is the effect that they're having on the other 3 horsemen, where they're increasing your risk by, 25 to 50%. So they really are gasoline on the fire of the other diseases.